Good morning, Diane. Good morning. Good morning, everyone.
Good morning, Demia. Are you ready for this?
I think so.
You're going to do great.
Thanks.
So,
Everyone.
Patrick, it's going to turn out to be really great. I think that we're excited. I think the ACH leaders are going to join us, and I think that a good group of healthcare authority from Washington is going to be here too.
Great.
Yeah, so it should be a really good meeting today.
So do you know, can you all hear me?
Yep, we can hear you.
Do we know how many people have registered?
Demia can look, I believe.
1 second, please. When I looked yesterday, I think it was it 19 or 22? Let me double check. Let's see.
19 or 22. There's got to be a lot of last minute folks then.
Yeah,
Yeah, we checked.
Yeah.
It was like, okay.
Usually it's like the day of.
Okay. So who's on the call right now? Just the three of us?
There's one more person.
Okay. And Wes is not going to be with us?
No.
Okay. All right.
We have 40 registered now.
All right. Picking up.
Good morning, Patrick. How's our fearless facilitator?
Yeah, glad to be here. I've been looking forward to this session for a long time.
Good. Patrick, for that land acknowledgement, if you would like, you could ask somebody from our audience to read it today.
Sure.
Nothing like putting them on the spot there, Carol.
You know, we, in the racial justice training that we're taking, they always ask for a volunteer, and people are a little bit hesitant at first, but it's really quite an honor to be able to read the statement. So I figured if nobody jumps in, one of the staff could do it. So
I was just teasing you, Carol.
you know me, I always put everybody on the spot.
Yes, you do.
Good morning, everyone. This is Patrick Jones, your facilitator for today, and I'll just wait for a couple more minutes to get the number of participants up to a slightly higher number, and then we'll dive into, I think, a really wonderful session. So stay tuned.
Patrick, did you see that Marianne Lindblad had tendered her resignation as of July 31st?
Oh, really? No, I
Yeah.
hadn't. Well, she's been there quite a while.
Yes, she's had a long history with Medicaid. I didn't realize that she was a nurse by training, but
Right.
Sue Birch wrote a very lovely email to you know, a bunch of the agencies, including the ACHs. So sad to see her go.
Yeah. She's had lots of responsibility for so long.
Yes.
She's a Spokane girl.
Oh, I didn't know that. Well,
Right.
you must be very proud of her then.
Yeah, kind of a famous name here. I think her brother or cousin is probably Spokane's best all-time golfer.
Oh,
So
Lindeblad, is that, I'm wondering if that's Norwegian.
Scandinavian of some sort.
Yeah.
So she's been over to Eastern to our shop more than once, giving talks.
Nice.
We have 42 people on the call now.
So why don't we go ahead and get started because we want to honor the time of our presenters from our neighboring state to the south and let them get on with their day. Good morning, everyone. Welcome to the May meeting of the Greater Columbia ACH Leadership Council. We have, I think, quite a set of fascinating speakers today based on our sister state to the south and their experience with the version of a waiver that we've been going through for the last several years. And so we're very grateful that the speakers that you're about to hear from have taken time out of their busy lives to come and appear before the 9-county group that we have assembled here for Southern Washington. And if we are in person, I would obviously go around the room and do something trying to be clever, but I'll just say that because of the Zoom format, we cannot do that. So I hope, just as taking the prerogative of the chair, and just to let everybody know that it's a dark, gloomy morning in Spokane, but I'm not unhappy about that because we have the first serious rainfall that we've had in probably 6 weeks. And I hope some of you, especially in some of the arid parts of our state, are seeing something similar, so we can all see our gardens grow and bloom. Just by way of background, if you haven't been to Leadership Council meeting before, this is one of 2 bodies that the Greater Columbia ACH has maintained over the years, the other one being our board of directors. And we come together usually every month in the course of a year and try to learn from those who are either in our group or who are outside of our group about the best paths to improve the triple bottom line of health. So with that, we could advance to the next slide, Damien. Just to let you know that there will be a document of this on the website afterwards. Usually that happens pretty quickly. And then if you wouldn't mind, I know that sometimes this is a bit of a chore, but it is a very, very short survey. If you wouldn't mind just keeping a little slot there for a quick feedback loop for us at the ACH so we can make even better meetings. With that, let's go on to the agenda. You can see that we're going to start out with the big picture of the Oregon experience from the Oregon State Medicaid Director. And I don't know if that's Patrick Allen or Lori Coyner. Can somebody enlighten me about that? Is it Lori or Patrick?
It's Lori.
Okay, very good. Then before the break, we'll consider a case study from the coordinated care organization that's closest basically to our geography from Sean Jessup. We'll take a break and then we'll have another case study, not from a CCO, but from a health council that I think will be very enlightening to see how that works with the CCOs. So we think we'll have time for questions at the end, and we hope you will pose questions. Don't be bashful about that, because that's how we all learn, is to probe a little bit and ask for a little more information. So with that, let's go to the land acknowledgement. And in the past, we've had one of our staff members do that, largely Carol, but we were wondering whether there's anybody on the call who wouldn't mind just reciting what you see there in the purple box as we acknowledge the land that we work with, the land that the 9 counties basically occupy right now, and just to keep in mind a very, very important historical part of our current lives. So would anybody like to raise his or her hand? I don't see a reaction going up on my Zoom screen. It would take about 2 or 3
Norma
minutes
raised her
at the
hand.
most. Brittany, would you like to?
Oh, I guess I can. Norma Hernandez was raising her hand, was what I was trying to say.
We can't hear you. If you wouldn't mind speaking up a little more.
Norma Hernandez has her hand raised.
Oh, Norma. Would you
Good
like to
morning.
then speak, Norma?
I would, thank you. Good morning, everyone. So it is the historic homelands of the 14 Confederated tribes and bands of the Yakima people, The Yakima people remain committed stewards of the land, cherishing it, protecting it, as instructed by the elders through generations. We are honored and grateful to be here today on their traditional lands. We give thanks to the legacy of the original people, their lives, and their descendants.
Thank you so much, Norma. That was wonderful.
Thank you.
All right, well, let's then start with some content from the staff. And this is a agenda item that we have dropped in the last few meetings, but we'd like to reintroduce. So this is a synopsis of the more or less of the newsletters, which I hope you received over the past few weeks. And I think we'll start out then with Carol, Executive Director, and we'll just take it in turn from the order that you see the reports in the newsletter. So Carol, take it away, and perhaps we can make that screen just a little smaller so people can read more than just a few lines.
Thank you, Patrick, and thank you everybody for joining us this morning for our Leadership Council meeting. I think it's going to be a great program. So the Greater Columbia ACH sends out a newsletter. The newsletter goes to about 1,600 people and organizations across our region. And what we've noticed is that our readership has dropped a little bit. So we want to make you aware of all the wonderful things that are happening in your region with regard to practice transformation, social determinants of health, any major events that are coming our way. So the first article is really just announcing that Greater Columbia ACH for the second time is granting $1.4 million to address the social determinants of health. What we do is we contract with third-party administrators. These are generally foundations or philanthropies that use their own processes then to distribute the money. I know that the Three Rivers Community Foundation currently has, I think, its applications open. Kirk could correct me if I'm wrong, if those have closed. I know Yakima Valley Community Foundation has their grant cycle open. So just wanted everybody to be aware in our region that these grants are available to address the high priority determinants as determined by the Local Health Improvement Network. So we work with the Local Health Improvement Network to come up with the list. They use their own processes, either through consumer surveys or through their community health needs assessments to arrive at these priority social determinants. And then the funding helps support organizations in their local areas to help deliver on those social determinants. So that grant cycle is open across our 9-county region. Here's the listing of those high priority social determinants in each one of the local health improvement networks. It's about 1.4 million total. And the way that the funding formula is distributed depends on the number of Medicaid beneficiaries and the number of social determinants that are worse than the state average in each local health improvement network.
Carol, the Benton Franklin Community Health Alliance and the Three Rivers Foundation grant application window just closed. Okay. But I know there is another round of their normal grant making process that will open shortly if it's not open already.
Okay, thank you, Kirk, for clarifying that.
Thank you, Carol. All right, are you going to cover this or?
That would be Heidi.
Okay, Heidi.
Hi, good morning, everyone. So earlier this month, we received good news about the Medicaid Transformation Project demonstration year 6. So we received a clarity on a Medicaid transformation for 2022 and the budget that includes the funding for MTP. And so for funds MTP to extension year 2022, this includes 101 million for Initiative 1 district for demonstration year 6, and Initiative 2 long-term services and supports, including Medicaid, alternative care, and tailored supports for older adults, and Initiative 3 for foundational community support, or FCS, were also fully funded for demonstration year 6. The supplemental budget includes the following adjustments to MTP, which increases the district year demonstration year 4 incentive budget by 37,518,622. And there are some allocations that the Medicaid Medicaid transformation provided, and the funds will be distributed in June 2021, scheduled to be paid in June 2021. So there's a link, I'm not sure. So the link is, this is actually based on the budget from that we got from HCA, and it's in their website as well.
I think the good news here that I can add, thank you, Heidi, is that because of this supplemental budget that was approved, Greater Columbia ECH is receiving an additional $2.3 million. So we're very happy about that, and we'll be able to use those funds for year 6.
Great. Thank you, Carol. So on to diversity, equity, and inclusion. Are you going to talk about that or somebody else?
I'll cover this one, Patrick, and this is just a short reminder that we are working on the next steps with diversity, equity, inclusion. Our March Leadership Council meeting featured Hadley Morrow, and who talked about her journey to diversity, equity, and inclusion. And so we are trying to get our planning together. We'll have a meeting next week with our workforce committee to discuss the plan, but that's just in process. We just wanted to let everybody know.
All right. Yeah. Okay.
And Wes is not here today. So again, just a reminder that last month we talked about community care coordination and community information exchange. So this article really just relates about how Greater Columbia is moving forward with that. This is a big topic among all of the ACHs, especially for year 6. We are looking at purchasing some type of platform that we can use in our region, and so more to come. This is going to be a big scope of work. Probably most of 2022 will be devoted in creating a governance structure and determining which platform that we want to adopt as a region.
Okay, thank you. And up next, Diane.
Yeah, so this is just a little reminder about the behavioral health internship program. Most of the providers are continuing to submit their final report, which is due June 30th. We did have 10 of the organizations that had some barriers due to the pandemic extend their contracts. And so those contracts have been extended for a year. So they will be until June 2022. We did have some good feedback from some of the organizations as they're turning in their final reports. And so we're excited to see what that looks like as we're getting those in. So more to come.
Okay, thank you, Diane. And
me again.
Also talk about the community health.
So we are excited. We have our community health internship program that's going to be launched here shortly. We had 11 applications that were submitted, and we are going to recommend to the board of directors today that we fund those 11 applications and the program. Hopefully we have some training that's going to be developed, and we are so excited to start this program. So it will hopefully the community health workers will start in July, and then they will go for an 18-month duration. So we're excited that this program is underway.
Great. Thank you, Diane.
Here we go again. But Becky's not here, but I'll just go ahead and talk about the Opioid Resource Network. So We are going to continue the Opioid Resource Network in Benton, Franklin, and Walla Walla counties. They've done a really great job. This year, they're going to be, their main focus is they're really going to be working with the practice transformation team and work with the providers in helping them understand how to get their patients into medicated assisted treatment if they need it. And they're also going to be working on some other things. They've anticipating that the OUD and the overdoses in the region have gone up. So they're really going to focus on distributing some naloxone into the community and doing some training with that.
Okay, almost there.
One more.
You want to talk about the toolkit?
Yes, so we still have toolkits available for the Practice the Pause. We distributed them over the 58 school districts already, and then we've also distributed them to all of the skilled nursing facilities in our area, as well as some of the assisted livings in Benton Franklin counties. We have distributed them to churches. We've distributed them to a lot of the community members. And so if you would like some, please reach out to myself or Brisa and we can get those to you.
Thank you so much. Okay. I think that's about it. Can we scroll down to obviously we don't need to talk too much about this, but is Chelsea, I don't think Chelsea's on the line, is she?
Yeah.
Oh, she is.
Hi, everybody. I'm Chelsea Chapman, the Business Development Manager. So I'm just going to cover a little business planning update. So as many of you know, we have hired health management associates to assist us with the development of our business plan. Last month, they presented on the findings from the rapid assessment, which included insights from focus groups and surveys conducted with our stakeholders. So thank you to those who participated. The goal was to gain feedback in areas that we could focus on in our sustainability post-MTP, given our core competencies in patient-centered medical home, convening leaders around regional health solutions, and advocating for whole person care and health equity. So among those key takeaways included the need for a succinct menu of services, while also recognizing that there's multiple strategies emerging for key stakeholders like Healthcare Authority and the ACHs collectively, as well as care coordination as a priority. So we are working as a staff internally to define a menu of services for next year that will, and beyond, that will complement our existing efforts as well as position us for some new opportunities. So we will hopefully have more information next month, or at least the summer.
Thank you, Chelsea. Sam, are you on the line?
I think one of the other navigators is going to do this one.
Yeah, Sam's on the line. This is Laurel Avila, one of the practice transformation navigators.
Can you speak up just a bit into the mic?
Sure. Can you hear me now?
A little better, but still not, you're kind of soft spoken.
Okay. So we had the Social Determinants of Health Learning Collaborative this month, and we really had good attendance and good participation. We provided some information and tools about how to screen for social determinants of health and how to address those. We had breakout sessions where there was sharing amongst our partnering providers about best practices and barriers, and if there are any solutions that they could share with one another. We did a survey, and some of our feedback was very good and also very helpful in helping us improve for the next learning collaborative.
Okay. I think that wraps it up then.
I think there's another.
Oh, you want to talk about yeah, go ahead.
This is Brittany. I am speaking for Sam, who doesn't have her voice today. Tomorrow we are having the Learning Collaborative for the MCO rosters. We did move that up due to the holiday weekend next week. So this is going to be a great learning collaborative in which we actually have the MCOs are actually going to be on this meeting and discussing with our sites, mostly the primary care, because they're the ones that do the rosters. And basically, it's going to be a great opportunity for them to collaborate and work with each other to ensure that what the clinic sites have and what the MCOs have are accurate for our patients. Because moving towards that patient-centered medical model is really the best practice to make sure that those rosters are up to date so that they can really care for their collective patients.
Great. And when will that be? What time of the day? Will that be morning or afternoon?
That's afternoon. It'll be tomorrow at 2 p.m.
Okay. All right. And last couple hours?
Yes, 2 to 4.
All right. So Chelsea, do you want to then wrap up with a brief overview of what happened at the State of Reform Conference?
Yes, so actually all of our staff attended the conference, and we all, or most of us, wrote a little article. So within the GCACH report, you can click and see all the staff takeaways, but I can just share briefly on one of my favorite key takeaways, or at least one of my favorite sessions I attended, which was the social determinants of health into a business model. How do you integrate it? Social determinants of health is super important. That's nothing new for all of us, but I think what stood out to me in that session was just the emphasis that we know that over 80%, where's my statistic? It says, it's been recognized that 80% of health outcomes are not determined by healthcare, yet it represents over 97% of our national health expenditures. And so shifting and integrating social determinants of health controls and measures upstream so that it can trickle down appropriately, and people will increase our health outcomes, which will ultimately reduce costs and make the world a better place. So I just thought that was interesting, but please go ahead and look at a report and see what the other staff had to say.
Okay, thank you. And of course, the ACH is spending a bit of time and resources on the social determinants of health. Anybody else from staff want to comment on the State of Reform, which has turned out to be their semi-annual meetings, kind of the highlights of healthcare reform in Washington State anyway. Anybody else?
Patrick, I would just add that this was the federal State of Reform, so there was a lot on federal legislation and what might be coming down the pike in terms of funding or emphasis from the new Biden administration. So I think that everybody got a lot out of it. Obviously, Wes's takeaway resulted in our meeting today and being able to reach out to the state of Oregon and looking at how they manage their waiver funding and what kind of progress that they're making with it. Mm-hmm. So I think that we are ready to go. I hope that our first speaker is on the line. I know that Sean is here, and just in case Lori's not. So I hope that Lori is here to give her presentation.
And Lori, are you there? Maybe not yet.
We are a little bit ahead of schedule. She was scheduled to come on at 9:30, and I'm sure as a Medicaid director, she's probably pretty busy. So if you wanted to, we could all talk a little bit more about the State of Reform and what we got out of that, Patrick.
Or I would like to just open up the floor to any questions of the 60-odd people who are on the line to the staff about the report, which you just heard. We really covered the gamut of lots of activities by the ACH, and I just wondered whether some of you have any questions, comments about all that you heard.
We have some questions in the chat here, Patrick, from Kirk Williamson. His hand is raised.
Okay, please go ahead.
I just put a link in the chat to a flyer for it's 3 extended conversations with Robbie Nelson from Catholic Charities about Practice the Pause. We want to take a look a little closer at the 3 different age group toolkits one by one so that people can ask questions. We're going to do it in webinar form in a couple of weeks, and it's open to anybody who wants to join us. The idea is, if your 5-year-old just bounced off all the walls in the house and was headed for the ceiling, we'll ask Dr. Nelson exactly how you would use the toolkit to slow the kid down or whatever is necessary for youngsters or teens or adults. So there are 3 different sessions. Thanks.
Hey Keith, this is Diane. I was wondering if there was a way that you could record those, and then maybe we could, you know, if you're putting them on your website, then we can share them on our website as well.
Yes.
If that would be possible.
They will all be recorded.
Great, thank you.
Okay, thank you, Kirk. Anybody else have questions of anybody on staff whose reports you just heard? There is a lot going on, and we're so grateful that the transformation project continues into, to some degree, at least from the outset, an unexpected another year, I think, which will give the ACH more time to really consider its longer term plans, and as well as continue the good work that I think, as you would agree, has taken place over the last 2 or 3 years. Okay, so we've got a couple of minutes before Lori is scheduled to speak, assuming she's not here on the line. Why don't we go ahead if there's any more comments from the federal state of reform. If I understand it, most of the staff went, and so anybody besides Carol have any comments, or Chelsea, on the state of reform day?
I know our navigators wrote up some very nice things to say about the state of reform. I don't know if they want to talk about that as they're waiting for Lori Coiner.
Sure, I can speak a little bit, Carol. I really enjoyed the state of reform. I feel that there was a lot of information on the political side of our healthcare system. So regardless of how we feel about that being a part of our healthcare system, the reality is that that does impact the, I guess, financial availability of healthcare to individuals. So it was really nice to see some of the things that are coming out of it. And I was really happy to see the technology piece in healthcare is finally being addressed like it should be. Still has a long ways to come. I don't think we're going to see anything happen tomorrow, but I was really excited to see that they're looking, they're understanding that telehealth, it needs to stay, you know, having better access for patients and letting them choose how they want to receive their care. So I was very happy about all of, hearing all of that, and hearing policy is going to be coming down the pipeline for that.
Great. Thank you, Brittany.
Patrick, I don't mind sharing as well if we have a little more time left.
Yeah, we got a minute or two.
Okay. One of the things that really stood out to me is how tech might meaningfully impact the healthcare outcomes we're currently experiencing. And I actually went to several different classes, but this was one of my favorite ones. And one of the key words that I got out of that is that digital technologies have been adopted more than any other industry in the world. We're not competing with machines, but changing the nature of work. Using technology allows you to take care of the easier stuff. And we must practice at the top of our licenses and not our bottom. We have to figure out a way to increase technology, and that technology can both increase productivity and hours of therapy. And so that was just one of the things that really stood out to me, because I know that we, with COVID, when COVID hit, we were kind of forced more so into the tele type of healthcare, and a lot of those systems are staying in place. They're just kind of reinventing themselves. And so I thought it was pretty good.
Yeah, yeah. Well, definitely a lot of work going on, and we just heard a brief snippet of that about the health information exchanges and the community information exchanges. And of course, there's lots of work, to put it mildly, going on in patient records. So thank you. Anybody else want to share? If we don't,
I'm going to ask Diane to share. I'm going to ask Diane to share her article. I'm going to try calling Lori Coiner's office. And if she's not available, I think we should ask Sean to go ahead and step in
Sure.
until Lori can join us.
Sure, you bet. So real quickly, before we turn to Sean, can we hear some more?
Okay, so the session that I wrote about was the behavioral health integration. And since the behavioral health integration is one of our project areas at GCACH that we've been working with our providers, I attended the session that says what we have learned about behavioral health integration. And they said that connecting to the body has taken a root in a number of states with the effort to integrate physical and mental health. This integration has come from in different forms as financial, clinical, from contracting to accountability. The conversation during this session at the State of Reform discussed many challenges of integration. This reminded me of how this had been for our behavioral health providers as we went through integrated managed care. They not only had to change all of their electronic medical record systems, they also had to develop an infrastructure that could support the billing of the billing to the managed care organizations and contracting with the managed care organizations. The behavioral health were encouraged to integrate with primary care in some way to provide that whole person care. And then I wrote that I'm really proud of how our providers within the Greater Columbia region have done behavioral health integration. GCACH continues to provide that technical support to support behavioral health integration.
Great. Thank you, Diane. Thank you. All right. Do we have Lori on the line yet?
No, it doesn't look like she's on the line. Let me check one more time here. No, she's not. Okay, so Sean's willing to present so that we can move forward.
Right. Okay. Well, we're going to reverse this then, just for logistics reasons, and start with the specific and then go to the general a bit later. But the general notion here is that we want to stand on the shoulders of giants, and I think we can say that Oregon has really accomplished, from what I've been able to read, quite a bit. And so we need to, I think, learn from them and see if we can actually stand to some degree on their shoulders, assuming they'd allow us to do that. So Sean Jessup is from Eastern Oregon Coordinated Care Organization, and he's got a very nice PowerPoint, which I've had the opportunity to review, and I hope you will be sure and ask him questions. So Sean, welcome, and the floor is yours.
Great. Well, good morning, and thank you very much for the opportunity to speak with all of you. Hopefully you can all hear me. I'll just pause, just someone give me the okay that you can hear me okay. Yes, okay, thumbs up.
Yes.
Good. Mm-hmm. So just real quick, my role with Eastern Oregon CCO, I actually have a couple of different roles. So one of my roles is I work for Moda Health, based out of Portland, Oregon. I'm the Vice President of Medicare and Medicaid programs for Moda. I've been with the company for 23 years and held a variety of different positions throughout that time, but all attached to Medicaid in one form or another. And then I'm also serving as the CEO of the Eastern Oregon CCO. Moda's a part owner in that organization. I'll explain a little bit more about that connection here as I go through the slides. So if we can maybe go to the next slide, and with Lori probably going to speak a little bit about CCOs and how they were developed. I think I'll maybe skip that next slide that I had, because I think Lori will be able to kind of frame how the CCOs came to be. But real briefly, Oregon was involved in creating CCOs, Senate Bill 1580 to create CCOs in 2012. Primarily, they were created because the state at the time had some significant financial issues. And rather than going through the standard things of cutting rates, cutting benefits, taking people off the Oregon Health Plan, Governor Kitzhaber at the time really had the vision to look at a coordinated care model that could save money for both the state and the federal government. So he went out, got $1.9 billion from CMS on a bet that over the next 10 years, Oregon could save the feds billions of dollars in their contribution to the Medicaid program in Oregon. And Oregon had some of that money at risk. They had to meet the trend growth targets. So 3.4% rate of growth target is the target that Oregon had to hit. That was a bet to meet some quality metrics. So some of that money was at risk, but that money was really intended to help start the CCOs, implement this experience, and see how successful it was. And I will say from my perspective, it's been quite successful across the state and successful for Eastern Oregon CCO. So some of the components of the CCOs were to engage the providers in the communities in a variety of different ways, including creating community needs assessments and community health improvement plans, combining benefits that were previously siloed, like behavioral health, dental, medical. The state previously would contract with each separate entities to cover each of those parts of the Medicaid benefit. And the CCO model was really intended to have one entity that was responsible for all that service, all those services, so care could be integrated together and delivered in a coordinated way. And then they had some rules about establishing the governance structure. So one of the beauties of the CCO model was, in the vision of it, is while we all had the same rules and obligations that we had to follow, each CCO really had the flexibility to set up their infrastructure to meet the goals and the intent of CCOs in a way that worked best for their local communities and their local providers. And it wasn't a one-size-fits-all approach to exactly how things needed to be done. So that was really a nice part of starting the CCO model. So let's go to the next slide, and I'll talk a little bit just about Eastern Oregon CCO in particular. So we are one of 16 coordinated care organizations in the state. You see the map here. We cover that shaded area on the right-hand side. Massive land area that we cover, 50% of the state's land area, but only 5% of the state's population lives in that geography. But we serve 62,000 members within the 12 rural and frontier counties that we serve, which is a little over 25% of the population being served by Medicaid. Of the 12 counties we serve 3 counties, Umatilla, Union, and Malheur. About 70% of the members live there, with the other 30% scattered across the remaining 9 counties. So next slide. I think our structure is unique in terms of EOCCO. So we are a limited liability organization. And MODA Health, again, based in Portland, we were the MCO serving Eastern Oregon prior to the formation of the CCOs. And then you see the next entity here, Greater Oregon Behavioral Health, Inc., or GOBI. They were the behavioral health organization serving Eastern Oregon prior to the formation of CCOs. So what we did was initially partnered with GOBI. We had a pretty short turnaround to implement the CCO model and to apply to be a CCO. So MODA and GOBI came together. We got things kicked off. It was a 50-50 partnership. But from MODA's perspective, we truly believe that in order for this model to be successful, and it really was an experiment, we wanted to have engagement with the key providers in the geography that serve members. And we wanted a relationship that was beyond just a standard provider contract. We wanted true buy-in and engagement at the entity level. So we offered ownership to a number of different providers and hospital systems in the geography. And you see here, shortly after the formation, about 9 months after we started in 2012, we brought on 6 different entities, 5 hospitals representing 4 different hospital systems are part of the ownership structure, along with the remaining IPA in Eastern Oregon and a very large federally qualified health center that we work with. That's been one of the greatest keys to our success, I think, because when you have engagement from a provider at that ownership level, automatically you have that tie that binds. So when we're creating initiatives or we need to hit certain targets, we have some of the key providers in the geography aligned with us to meet those goals. We have an 18-member governing board. We expanded our board beyond some of the Medicaid required board positions. So we have county commissioners on the board. We now have dental representation on the board. And then we have members from the community, including an Oregon Health Plan member consumer on the board as well. One of the other keys to the structure, the CCO, the state required CCOs to have, in each CCO have one community advisory council. And that's where you get that consumer and member voice into the model. Well, we knew when you saw that last slide that our geography is huge. And just you think about trying to get people to a single meeting across Eastern Oregon, across those 50,000 square miles, that wasn't practical. And we also knew the needs of Umatilla County are much different than the needs of Lake County and much different than the needs of Malheur County. So in our structure, we set up local community advisory councils, one for each county. And the local community advisory council chair, along with the county commissioner, county judge, serves on a regional community advisory council, and the chair of the regional community advisory council serves on our board. So that's how we would get information from the board down to the regional community level, down to the local level, and the local level would report up to the regional community advisory council and then feed information up to the board. But that's how we ensured engagement across all 12 counties, and that continues today. And then we also have a clinical advisory panel of EOCCO where we engage clinicians. They've helped us develop a number of initiatives. They've designed our primary care provider quality bonus payment structure. They've selected the quality measures primary care providers and others should be at risk for. And they've made a lot of recommendations to us on policy, benefit coverage changes, etc. So also very valuable to have that clinician voice in our structure. So next slide, please. Just brief on administration. Moda Health is the traditional insurer. We essentially run the organization. One thing that's unique about EOCCO is we actually have no employees. EOCCO is an entity. So all the work is administered primarily by Moda. Gobi, our behavioral health partners, managing the behavioral health benefit. They also oversee the medical transportation benefit, and then they provide staff support to our community advisory councils. Our prescription drug program is offered through the Northwest Prescription Drug Consortium, which you may be familiar with in Washington, or OPDP for Oregon. That's been very successful, part of our model. And then we have two different dental care partners, Advantage and ODS Community Dental, which is part of the Moda family, serving the Medicaid members dental benefits across the 12 counties. Next slide. We'll just touch on our delivery system. 10 area hospitals within the 12 counties of EOCCO. 7 of 10 are critical access, 5 belong to health districts. We have no tertiary hospitals. So the reality is, beyond keeping care local within the 12 counties, we had to establish contracts and build a network in Idaho for people that live on the far east side in Malheur County. In Washington State, so the Tri-County area, Tri-Cities area, we have a number of providers contracted. In Portland as well, OHSU, how do we provide that really high intensive care? So our network is clearly beyond the 12 counties as well. Primary care providers, about 60 primary care practices that serve the geography, number of rural health clinics, federally qualified health centers. And one of the things we're very proud of is that 95% of our members are served by a state certified medical home. That's an Oregon designation, PCPCH, at tier 3 or above on a 1 through 5 tiering system, with 5 being the highest. So we're very proud of that work. We've made a lot of investment in primary care. We've made a lot of investment in helping clinics become state certified as a patient-centered primary care home. And when we started, we only had 1 medical home in the entire Eastern Oregon geography. Now, again, 95% of our members are served by 1. So one of our successes there as well. So next slide, please. So these have been some of the principles of our principles, and these principles have led to a lot of our success and really tie to what some of the CCO requirements are. as well. So when we started, there was an intent to implement value-based payment models by the state. No requirements under our first 7-year contract on exactly how to do that or where we needed to be. It was really up to us to figure out how to do that. So we were starting in an environment of cost-based hospitals, 100% fee for service. Providers, for the most part, there's a few exceptions, but for the most part had very little experience with value-based payment models. So the first thing we did is really took a crawl, walk, run type of approach. We started with a shared savings model that essentially providers would put 5% of their payments at risk. And for that risk, they could share in savings. And so what we did is essentially our actuaries set a budget, and if costs for EOCCO membership collectively came in below the budget target we set, and on an annual basis, there would be a surplus, and we would share that surplus with hospitals, specialists, and primary care providers. That's been very successful, and we've had a payout every year, other than 1 year we had a break even. So no one's lost money through the model. But that allowed us to continue to have conversations and to try new models. Again, we make additional payments to patient-centered primary care homes, kind of a case management PMPM that's on top of their normal payments. About 65% of our primary care practices are now on a capitation payment model. When we started, there were 0. We have PCP bonuses for meeting quality payments, and then we have some different full risk models. So again, that's been a key to success and where we've gotten a lot of trust built from our provider community. Obviously, we want to operate within the global budget target. We've been able to do that some years, but not all years. That 3.4% is really a statewide goal for all CCOs across the state, not necessarily each individual, but the fact that we've been able to do that in a rural geography a couple of different times, I would say is a success. To meet state mandated quality metrics, this is key. So one of the really good things that Oregon did is they put additional bonus money available to hit quality targets. And as a CCO, if we meet 70% of our quality bonus targets, we're able to earn 100% of the bonus available to us. I'll show a slide of what that amount looks like. And our model's been to reinvest 100% of that quality bonus money earned back into providers and communities. So at the CCO level, we keep 0 of that. It's completely a reinvestment and rewarding providers, rewarding the community for their efforts and helping improve quality. And then we've used part of that quality money to reinvest in a number of different projects. Our community advisory councils get funding every year. We have a grant program, et cetera. Next slide, please. So I'll touch briefly. Here's what that quality fund bonus amounts look like. So at the top of the chart, you can see in any given year, I mean, it's a substantial amount of money, $12, $13 million that we've earned based on our performance. So this is just for EOCCO based on our performance. We've gotten between 90 and 100% of our quality money earned most years, but you see the different categories where we've invested. We fund patient-centered primary care homes through those care management payments, quality bonus payments to PCPs for helping us meet quality targets, our community benefit initiative grant program, our community advisory council grant program, and then we have some dollars that we've started to distribute to our dental plans because there's some dental quality metrics, and more recently in the last couple of years, more and more behavioral health metrics have been added on to the formula, so beginning to reward our behavioral health partners as well. Next slide. So this just gives you an idea of the measures that are at risk. These measures are determined by Oregon's Metrics and Scoring Committee. Part of a broader list of measures, but these are the measures that CCOs are held accountable to. So a number of claims-based measures. We have some chart review measures that require, we mine data in the clinical records, and then some clinical quality measures as well. And some of these are probably familiar to any of you providers that are on the call, but there's some Oregon-specific ones in here as well, such as ESPERT. Next slide. And then just a little bit about additional initiatives that we've used as investments with some of the quality dollars. And I'll go in just a layer deeper into some of these because I was asked to talk a little bit about our efforts around social determinants of health and traditional health workers. But one of the things that we did through pretty successful grant in one of our early years is we had a lot of success with a community health worker grant program. So EOCCO used some of those quality dollars. We made a pretty significant investment in building out a training program in an effort to build up the community health worker workforce in Eastern Oregon, including reimbursing for the services they provide. We've invested in different types of technology. So one of the challenges we had in our geography is a lot of different EMR systems being used across the 12 counties. Not a lot of Epic happening, especially when we started. That's changed a little where some of the hospitals have been able to tag onto a bigger system's Epic. But how do we get access to the clinical data? As the payer, we have all the claims data in the world we want, but we need that clinical data as well. And how do we help the providers know how they're performing, not just with claims data? So Arcadia Solutions is a company that we partnered with for the last several years. We're able to go into practices, connect to the EHR, they're EHR agnostic in terms of their program, bring that clinical data in, combine it with our claims data. And then now we have a package of data, clinical and claims combined, where we can measure performance and our providers can see their performance on claims and clinical measures. And so again, that's partly tied to our ability to close gaps and know how they're performing on the CCO quality measures. We've funded pre-manage for our practices. We're also evaluating CIE through Unite Us. That's kind of taken hold in Oregon, and we're planning to implement that later this year for EOCCO. We've had a regional opioid prescribing group that was formed. That was a spinoff from our clinical advisory panel. We have no pain centers in Eastern Oregon, not a lot of resources to address pain and the opioid issue that we had. So this group really helped do a lot of forums. We got a lot of providers trained, get their buprenorphine waiver training. We had some performance improvement plans, and we've been able to bring down the opioid rate quite a bit in terms of opioids being prescribed. And we look at buprenorphine and Suboxone rates going up and up and up. So we've really, I think, had a positive impact on trying to deal with the opioid epidemic in Eastern Oregon. And then we're looking at implementing or planning to implement qualified and certified healthcare interpreter training in 2022. Next slide. So I'm going to talk a little bit more about our community health worker initiative. So if you can go one more slide, please. So I mentioned a little bit the successful grant we had, and we were trying to figure out how can we get more community health workers trained, because they provide such a significant value to the practices and to the members, and also helping members address social determinants of health. And I know that's probably familiar to all of you. So one of the challenges when we went down this path is how do we get people trained? And one of the biggest barriers we had is that the idea was a lot of existing staff at the practices maybe would receive the certification, and it wasn't practical for them to travel somewhere and take a week or two off to attend a training. You know, the providers' practices couldn't afford to have them leave for a long period of time. So we partnered with Oregon State University and their College of Public Health to create a community health worker training program for EOCCO. We've had this partnership since 2015. They've gotten state certified as a community health worker training program. The idea is to train entry-level community health workers on a blended format, online and synchronous. And so this helped with a lot of the travel issues and the time away for staff. Of course, it's been online through the pandemic, and then we were able to negotiate kind of a reduced rate for the EOCCO population. We wanted this to be more than just an entry-level training, so we also provide some continuing education modules, and we're looking at developing a leadership module as well. That's been a success. We've trained 215 community health workers in Eastern Oregon through this program, and really been able to expand that workforce. And though our model is the CCO doesn't employ them, they're employed either in public health and primary care, dental practices, behavioral health. We just wanted to facilitate the workforce and the training so they could be deployed and used in the way that works best for each of the practices. Next slide. And that success of the program has really led us to engaging with Oregon State University to develop a community or a healthcare interpreter training program. So So this is going to help us address some of our health equity issues that we're trying to address. It'll support work within our health equity plan. There is a future CCO quality measure coming on language access, where we'll be measured on how many qualified and certified interpreter trainings were delivered in 2023 and having a target for that. So again, the idea is build a workforce, provide a solution, keep people in the office where they can be trained so they don't have to travel for a long period of time, and really enhance that partnership with Oregon State University. We also intend to have an apprenticeship program as well to help with the practice hours that are needed, and intend to provide some scholarships to get more of a lot of people can translate in the practices, but they don't have the certification that will soon be required. And that's the goal we're trying to accomplish. Next slide. And then one more. Just a little bit on our community benefit initiatives that we mentioned, several, almost $9 million invested back in the community since our program started in 2016. These are transformational projects selected by the communities, whether it's our local community advisory councils, providers, public health departments, just innovative programs, all designed again by the community. And if we can go to the next slide, please. So these are just examples of just a few of the projects. One of the things that we did was we contracted with Oregon Rural Practice-Based Research Network, or ORPRN. It's part of OHSU here in Portland. We wanted to have an independent review of the grants, and they really helped us manage the whole application cycle, managing the grant process, having independent reviews of the application, because we didn't want it to be biased where EOCCO is picking and choosing, which programs, which providers to invest in. So that's been very successful, having that independent review. Gave us buy-in from the board. And a lot of the projects over the years have been really focusing on social determinants of health. Have a number of Frontier VegRx programs now operating in 4 counties. We funded a warming station in the winter in Union County, a variety of different housing vouchers, wellness fairs. A lot of the measures are around social determinants of health, or the initiatives around social determinants of health, helping us meet the quality measures. How do we engage the community in the grassroots efforts to help push initiatives, help us meet metrics beyond the walls of the provider practices. So again, a very successful program. And another way to really get that buy-in and engagement from the community, give them something exciting to work on, something that they know is an issue in their county that they can apply and get funds for and have investment from the CCO. Next slide, please. And then if I just summed up kind of all of our efforts, really from when we started through about June 2020, and we need to reevaluate our numbers. But if I added all the things up that EOCCO has invested in, this is above and beyond standard provider payments, that we're making. We've been able to reinvest $150 million back into providers in the community through the CCO model. And I can guarantee you, if this is just a traditional insurance model, where we're just the insurer and we're taking the savings, that money wouldn't be reinvested. But the CCO model is set up in a way that beyond the financial minimums that we have to have in place, our goal is to reinvest back in providers and communities. And that's exactly what we've done. So pretty cool story, I think. And then I just wanted to mention just a tiny bit on the new contract that we're operating under, which is called CCO 2.0. So all the CCOs had to reapply in 2019 to have a new 5-year contract in 2020. So if you can go to the next slide, please. And one more. So the focus areas of CCO 2.0, and Lori again can probably talk about some of this, but see, these were some of Governor Brown's priorities: improving the behavioral health system with integration into primary care and primary care and behavioral health, focusing on value and pay for performance. So this is taking the value-based payment models I talked about earlier, but more prescribed in terms of specific goals the state wants to meet. Obviously, health equity and social determinants of health is a significant initiative for all of us, and then continuing to maintain that cost growth target. And then my last slide on just a couple examples of what that looks like, because we're right in the midst of implementing CCO 2.0. Things were kind of delayed in 2020 with COVID. So a lot of things have kind of been pushed into 2021, but some significant changes of CCO 2.0. One of those is risk-based capital requirements. You know, as a CCO, we have to have financial reserves for protections in case of solvency, but we have moved to a much more regulatory environment under the CCO 2.0. So we've had to basically double our financial reserves. That was a challenge for us because our model of getting money back out to providers and communities, we've had to have the owners had to put in additional capital actually, and we've had to save some of our surpluses to build up to meet these new risk-based capital requirements. We have a lot more reporting requirements. So we used to have about 60 reports a year we'd have to send to the state. Now we have over 200. There's a lot more regulatory work that the CCOs have to do. And then there's a lot more prescribed requirements. So I mentioned the value-based payment models. We have a goal to get to 70% value-based payment models by 2024. Health equity requirements. We've hired a health equity administrator to help us with that work and submitted a health equity plan to the state. There's a social determinants of health requirement investment called SHARE, where we take a portion of our prior year's net income, invest that into a variety of social determinants of health domains. One of those being needing to be around housing supports and services. So we're doing that for the first time in this calendar year. Traditional health worker requirements. So you saw we've done a lot around community health workers, but we need to do more around doulas, around peer support specialists. But how do we build up that workforce and pay for those services? And then some health information technology requirements. How do we get more and more providers on a certified HIE as an example? So these are all the things that we're working on under 2.0. 1.0 has been a lot of fun. We've had a lot of successes, and now we're seeing what we can do to meet these requirements of 2.0 and continue to move the delivery system along. So sorry, I may have went a little bit long. I apologize, but I will stop there and happy to take questions, or I can hang on and we can take questions later, however you want to handle it.
Well, thank you so much, Sean. That was terrific. I just have many questions, but I don't want to use my position to ask questions. I'd like to hear from those online, those on the call, and whether you're a provider, whether you're a community-based organization, whether you're an MCO, I'd hope you have questions for Sean. And so if you wouldn't mind, just raise your hand and we'll try to get to those questions. And then if we run out of time, if you can stay on the line, Sean, we'll do this after the break as well. But for now, any quick questions of what you just heard? That's quite a synopsis of several years worth of innovation. Anybody have some questions? I see no hands raised, but I'm sure there are some shy ones who have some questions. So no question is a bad question. Okay. Anybody, let me put our MCOs on the spot a little bit. And I don't know who's on the line from our MCOs, but I would like to know if you've been in conversation with MODA or any of the Oregon-based MCOs.
Excuse me, Patrick, we do have a question, looks like from Sam in the comments here. What is the responsibility of the PCP in the CCO model?
Okay, why don't we take that for now and see if anybody else comes up with some other questions. So can you take a crack at that, Sean?
Yeah, that's a big question because they do a lot. But in the, in our model, I mean, what we ask of the primary care practices, help us meet the quality metrics. I mean, that's one of them. Consider opportunities to accept different types of payment models. So we've talked about capitation as a model. Help us close gaps in care and quality. Participate in our clinical advisory panel. If you're really interested in problems you see or how we can move the delivery system forward, participate with us, whether it's on our board, whether it's on our clinical advisory panel. But I mean, at the end of the day, we want them to take care of their patients. We want to reward them for their work. We want to provide them data on their performance and be a partner with them. So a pretty broad question, but you know, we want them to do the best job they can, and hope we're not getting in the way, and hope we're helping them in their work.
Okay, and to just follow up with Sam's question, is the patient, I think you want to say, okay, yeah, impaneled to a one provider, and how does it work if they want to change providers?
Yeah, good question. So yes, all the members we attribute all members to a medical home. So not necessarily a specific individual provider, but typically to a practice location or a clinic, because what we often see is that in any given day, you may not always see your same provider. You may have to see the PA or nurse practitioner. So we do attribute members to a clinic or a practice. We first give members the choice to pick the provider or the practice they want. And if they don't, we look at claims history and try and attribute one. And if they have no history of a medical home assignment, then we will assign the member to a provider. And they do have option to change. So there's a couple times a year, if they came to us and say, hey, you know, you assign me to a provider, I've never seen him or her before, I'd like to go to this other clinic. Obviously, we'll facilitate that, but we do give members, I think our policy is, you know, twice in 6 months, an attempt to change their primary care practice. We don't want people moving constantly and have some continuity with their medical home, but we do provide a member choice in moving.
Thank you, Sean. That makes sense. Okay, you know, I think in the interest of keeping on schedule, we'll go on and have Lori speak now. But Sean, if you have the time to stay on the line or come back on the line around 11 o'clock, I'm sure there are some more questions for you, and you have so much to share with us, I think. So
sure. I'll be happy to hang around.
Okay, thank you so much.
Thank you.
So I did see that we've got Lori Coyne with us, and if you could pull up her PowerPoint. Here we go. And it's a short one, but I'm sure there will be questions even among the 7 or 8 slides we've got from Lori. And so let's see if we can get started and learn more from the, I don't want to say the 30,000 foot level, but from a statewide perspective. So Lori, the floor is yours.
Great, thank you. And thanks for having me this morning. The slide deck that I have here, yes, it's very short. I'm going to speak probably in a more lengthy manner off the slides. And this was a presentation that Patrick Allen, our division director, gave at the State of Reform, but it gives a nice summary of kind of where CCO started. And then I'm going to speak to this is really, I think, where they started, and we are now in the process of developing the third waiver around CCOs, and kind of give you a bit of a history and then where we're going. I did just send Carol a much longer slide deck about with more details and a kind of our policy frameworks for the current waiver that we're working on. I'm not planning on walking through all that, but it's great. I told her she can go ahead and distribute it for background, and if we need to pull it up, we can. So next slide. So let me give you a picture of why Oregon created CCOs in the first place. And also I'll give a little history for me, since I've been around the agency for a while. Back in 2011, 2010, actually, the CCOs, there was a lot of uncertainty in our managed care plans at the time in terms of budget and how, you know, what they were receiving in terms of funding was tied very closely, you know, to our state budget, as in most states. And there'd been big provider cuts that had happened in previous years, and there was lots of consternation about that. And so part of our first goal was to develop small, regionally focused managed care entities called coordinated care organizations that first off would have a global budget so that funding streams were integrated. At the time, there was lots of different funding that was coming into the entities, the existing ones, that so they'd get a behavioral health rate, they'd get a dental rate, physical health, other kinds of funding, that wraparound payments for care coordination, and it would all come in kind of separate buckets. So part of it was to braid the funding together, and then we really worked on what we called a global budget, which was a monthly amount, based on a per member per month, but one fee that would cover all the services that that CCO provided, and that it would increase at a sustainable rate of growth. And providers and CCOs at the time said, yes, we would rather have a smaller rate of growth. No, as long as we know that we are going to get some sort of sustainable increase. It's so much better for our planning, our contracting, the way that we deliver care, if we have some sort of predictability. So there was that. The other piece was this idea around, the triple aim was a big focus at the time, and there was a real need to think about how to provide better care for members at lower cost, and really think about improving the overall health of members. And so, and I guess I want to get back to this funding piece. At the time, the only levers that we had for maintaining costs in the Medicaid program was either cut benefits, cut members, or cut provider rates. And we wanted a different path, and that was to have global budgets, sustainable rate of growth, and really think about how that money is spent with a more of a focus on upstream expenditures to improve the health of individuals, and thereby cut overall medical spend. That was really the beginnings. Other big focus areas in that and there was legislation that happened in 2011 related to this. There was lots of pre-work before the waiver went through. It was approved in July of 2012, and there was a focus on this idea of efficiency, so reducing waste and costs, align these financial incentives so you're getting a global budget, pay for quality and better health, and a huge focus early on care coordination and patient-centered primary care home development. And so the initial focus, and I think Sean got into this a little bit, was really building primary care in a coordinate, so that it was coordinated and provided high quality primary care services to members. So I'm going to pause there and see if anybody has questions before I move on.
Any hands up?
The other thing I want to mention that was a big new piece of this was that when we were negotiating with Center for Medicare and Medicaid Services, this idea around a global budget and that we were going to hold costs down to 3.4% rate of growth annually, was that we needed to show that we weren't going to do that at the expense of quality and access. And in order to do that, there were lots of negotiations. We still report to the feds quality metrics. There's 33 kind of quality metrics that at the time, if they were degraded, we had a test, we would lose some of our funding. We always met the test. And then there was a quality incentive program that was developed. And at that initial incentive program, it was 1% of CCO budgets that was paid out in an incentive based on 17 incentive metrics. I was brought in January of 2013 to develop that program. So that, I guess that's my history. And we created the Oregon Quality Incentive Metric Program that's been quite successful, at least in improving the areas where we pay on metrics. And now we pay this year 4.25% of CCO budget. So it's increased most years, and that was the vision, to eventually get to 5%. So next slide. And so speaking of those metrics, here's some examples of what the coordinated care organizations have accomplished across time. I'm not able, let me see here, to see what year that is. Can someone tell me what year those are? My screen is really tiny. Maybe.
2011 to 2019.
Let's see if I can do it here.
Lori, it's
yeah,
2011.
So 2019, great, I made it big. 2019 data. And so you'll see 2011, we considered the baseline year. That's before CCOs were in existence. And so we've had huge increases in things like developmental screening, health assessments for foster kids. ED utilization has decreased from 61 to 47, and that's in per thousand, I think, visits. I'm not sure what the if it's per 1,000 or per 10,000, but you can see that ED utilization has dropped pretty significantly over time. We did definitely have learned that the metrics that you pay on are the metrics that move. Like I said, we report on 33 other metrics, and while we see modest improvements, we don't see the same level of improvement that we do with the incentive metrics. And as I think Sean talked about at the end, you know, the most all the CCOs at this point have their provider contracting tied to metrics. The other thing and I could do a whole talk on this particular topic, and I won't, but I will say that the metrics have gotten harder over time. We're really looking at metrics that get closer to outcomes. There's a new metric that, for example, that's related to equity in the sense of providing services for people who do not speak English, and that's new this year. Next slide. So Sean talked about CCO 2.0 contracting, but before we get to that, I'm going to talk a little bit about what we learned in that first waiver period and what happened in the second. So our first waiver was, like I said, awarded in July of 2012. And our next waiver application was approved in January of 2017. I happened to be Medicaid director by then and negotiated that waiver. And we learned, we were working really hard to kind of move the CCO model forward. So a couple of big successes that we learned in the first iteration of CCOs were these. I think local accountability and care was really important in our model, and it was, I think, a very valuable piece of it. So, for example, just to kind of piggyback on Sean, Eastern Oregon, 12 different counties. They're the biggest CCO in landmass, not in numbers. And, but, you know, and they were committed to having, you know, working with all 12 different counties, having community advisory councils. But I think that's been a real important part of their model. The other piece was just the growth of certified patient-centered primary care homes. At the time when Eastern Oregon started, there were essentially no patient-centered primary care homes in all of the Eastern region. And one of our initial incentive metrics was to each CCO, in order, it was kind of a floor, you had to get, have 60% of your practices or your members enrolled in a patient-centered primary care home. I believe Eastern Oregon's up around 90% now. And so that was a huge focus. And we really focused on integration of behavioral health and dental within those PCPCHs. The other pieces that were, like I said, the incentive metric was a real positive. Some of the areas where, and I think that the braiding the funding together so that CCOs had more of a global budget was also really positive. In that second waiver, some of the areas that we were trying to move forward. One was the use of health-related services, or at the time in the first waiver, we called them flexible services. So these are non-encounterable services that improve health, but are not something that you can code for. So, and we refined a definition of health-related services to be two different things. It can be a flexible service that might be provided to an individual. So let's say a CCO wants to pay for mold abatement in a child's home where they're experiencing lots of asthma events and in the hospital a lot. So that there was also community benefit initiatives where a CCO might invest in walking paths in a affordable housing division so that people get out and exercise. And that would be something that was provided to the entire community. Those types of services hadn't been utilized very much in the first iteration, and we really wanted to try to expand that. So we spent lots of time negotiating with CMS around how to have health-related services more easily utilized by CCOs. And so what happened was that they weren't counted as a benefit. They're not counted as a medical expense, but for purposes of the medical loss ratio that CCOs are held accountable towards, they do count to that. We also really wanted to expand the global budget definition, didn't get too far. And then on the behavioral health side, we had quite a number of initiatives on housing and some coverage. We were seeking coverage for certain times that members were incarcerated, and also in the state hospital for better handoffs, both around medication reconciliation and handoffs for people, particularly with behavioral health conditions, but other physical conditions from an institutional setting to the community. Unfortunately, we were negotiating our waiver in the middle of an election. I know Washington was right there with us, and we had to dump most of that policy in order to have our waiver approved in January of 2017, rather than when it was going to be expired, which was June of 2017. So we made lots of kind of moved things forward in terms of some behavioral health initiatives, and we also changed our model so that dual eligibles would be auto-enrolled in CCOs and they could opt out. That was another piece of our second waiver. Then came along our CCO 2.0 contracting, which Sean just talked about at the end. And the governor, our Governor Brown, she wrote a letter that basically outlined these 4 areas that she wanted us to focus on, and really in learning kind of across time, areas that we needed to focus on in the future were these 4. And there's really a 5th that's not listed here that I'll talk about. So one's focus on improving the behavioral health system, increasing value and pay for performance. So Sean talked about the pay for performance requirements. Continuing to focus on social determinants of health and health equity. And this is really that area around health-related services. And then maintaining sustainable cost growth. So continuing to focus on this 3.4% cost growth target. And the final one is we'd had a number of audits by CMS and the Office of Investigator General around our oversight of CCOs, and basically had to step it up. And so part of the contracting also, as Sean talked about, there's a lot more regulatory guidance and requirements. And some of that was from our community saying, hey, you need to hold the CCOs more accountable, but also it was pushed from the federal government. Next slide. So and as Sean mentioned, CCO 2.0 started with 2020 contracts. We are now into 2021, but with the pandemic, we kind of scaled back some of the pieces that we were planning to move forward. They're still happening. We're we're just slowed down the progress on it. And in CCO 2.0, I guess a couple notable things. There was a focus also on a health equity plan. So CCOs have to submit that, a behavioral health plan on how they are going to integrate their system. So not the first iterations of CCO, the focus was on integrating behavioral health and primary care. And here is really thinking about the broader behavioral health system and how to integrate, and particularly around those transitions of care. And then the final piece is utilizing more traditional health workers, community health workers, peer support specialists, and other types of workforce that's culturally aware and linguistically appropriate. So where are we now? We're right in the beginnings of another waiver application. Actually, we're doing lots and lots of public engagement. This one, the initial focus was to create an equitable system of health, and what we're thinking here, and this is where some of our behavioral health work kind of is falling. Well, let me back up. Our waiver application is due in December of this year. It will needs to be approved by June of 2022. And the overarching focus on our waiver application for this time is on improving health inequities in Oregon. And we have 4 big policy areas that fall under that. So the first is creating an equitable system of health. In this area, we're going to be focusing a lot on transitions. So we're going back to what we were thinking in 2016 and working on Medicaid coverage for people the 30 days before they leave the criminal justice system or state hospital or a psych residential facility, thinking about kids aging out of foster care. We know that those transitions are where there's lots of difficulty with handoffs and the like. And so we're going to be asking the federal government to cover more of that. We're also going to be asking for more health-related serviceability in thinking about meeting social needs. We're going to frankly try to ride the coattails of what California is doing right in their waiver that's coming up, and also what North Carolina was approved. Happy to talk more about that if anyone's interested. And that's really the focus of, we aren't focusing specifically on behavioral health in the waiver. I think this area around transitions and then meeting people's social needs, we know that there's lots of inequities in those transitions, and we know that they're largely affect people with behavioral health needs. We're going to further our progress on cost containment. And in this area, we're thinking, again, we are going to be pushing on a real global budget. So that's also going to be at a sustainable rate of growth, and going to go back at that with CMS again. We are talking about providing some portion of the CCO's budget to for communities to have power and control in how they invest those healthcare costs. So we're still working on that, and we're actively engaging with community on that topic. The other is access. We want to continue to think about access and coverage. We're hoping to reach 98% of Oregonians on some sort of coverage, and this will need to be covered with worked out with a 1332 likely. So more ties to the marketplace. Also, we've learned a lot about coverage and in the pandemic, and how to extend coverage for members so they have more continuity of care. And then the last is thinking about, we will be asking the federal government around, we have been holding our costs at 3.4% for over 10 years now, and looking at some shared savings in those savings, and targeting those shared savings on investments at the system level as opposed to the CCO level. Next slide. So I think just to add on final comments, global budgets are the way to go, but they are it's hard to achieve, and it's hard to achieve mostly because of the focus now by CMS on actuarial soundness and some other aspects. I think we're going to get there this time, but it's you know, it's a challenge, and there's a whole history behind that. I'd be happy to explain in terms of CMS's requirements by the GAO, Government Accounting Office, and they had to step up their review of fiscal accountability of states' Medicaid budget, budgeting and rate setting. Another big piece that's been very important in our model is this culture of innovation and a willingness to work together. So we meet with the CEOs every month. That's leadership. So me and Pat, our agency director, and Dave Baden, our CFO, we meet every month, have dialogue with the CEOs. You know, we work closely enough that Sean can call me or I can call him on our cell phones when we've got issues. And I think that's really important, because if you're going to change your model, you got to do it all together. We also have a lot of local folks working hard on this. I think some of the modeling around community advisory councils and engaging local government and members of the community is key. I will say our insurers are different. Our CCOs are different in that they're largely local and mission driven, nonprofit, come from the community. We don't have a lot of, we only have one large national plan in our among our 15 CCOs. And then, you know, right now we're focusing on equity, and it really does kind of require even more rolling up your sleeves, working together, and thinking outside of the healthcare box. Next slide. I guess just some last thoughts. So when I was talking about coverage, you know, we are looking at the possibility of applying for a 1332 waiver. We'd like to have a lot more connection between Medicaid and the marketplace. And how can we take what we know that works? And from our CCO model, you know, this patient-centered care, ensuring access to care, paying for outcomes, setting a cost growth target, and transparency in everything we do. We're hoping to extend, you know, into private markets in Oregon so that there's consistency, and also that we've got lots of experience in terms of understanding, you know, what works. And I'm going to end there and just entertain questions. And hopefully this was helpful.
It certainly was for me, Lori. Thank you so much. That was fascinating, what you and Sean have presented so far today. We're running a little bit late, but I think I'd like to break the agenda timeline a little bit to have some questions of Lori here before we take a break.
So Patrick, I'm going to take executive director privilege here and just again thank Lori for jumping on our call. I think there's a little bit of miscommunication there. Sorry, Lori. How did you convince, you know, your local rural providers about global budgeting? I think there's been a lot of concern in the state of Washington that global budgeting won't cut it, especially for these smaller provider organizations.
So I'm going to start at the big level, and I'm actually going to let Sean, who has done the most work on that of probably anyone in our state in terms of talking to small local providers. But what we did, I mean, we had to have the CCOs at the table at the beginning. And in fact, right now, I'll just tell a quick story about it. We have a small group of CEOs meeting on our waiver. It's just a handful. And I had a couple who have been around since the beginning kind of tell their story of how all this started on global budgets so that the others could learn. And they were talking about how there was a group that the governor had put together. This was Governor Kitzhaber, to talk about, you know, bring everyone around the table to say, yes, we are going to be okay with a global budget. And there was a provider from one of our big hospitals who at first was absolutely opposed, and then finally came around to saying, you know what, if we can have some predictability here that we're going to grow at a certain rate, we can do it. And he said that was really the turning point. But the CCOs, you know, that applied and initially came in the game really had to be committed to that idea, and that they were going to work on that with their providers. And like I said, when Sean started, they essentially had not any certified patient-centered primary care homes. I didn't know that if they'd be able to make that first metric of, you know, having 60% members enrolled. And so they've really done heroes work on that. And I'm going to let Sean speak to his experience.
Sean?
Sure. Yeah. And I'll just, before, you know, Lori's been a great partner. And like she said, you know, it's good to be able to just pick up the phone when you have a problem or we're having a challenge with a requirement, or, you know, need a break on something. You know, they've been reasonable, and she's been reasonable in terms of listening to us and doing what she can to help. And that helps. You need to have a good partnership with your regulators and your Medicaid director. But in terms of, you know, what we've done around the global budget, you know, one of the things that I think Lori mentioned was in this next waiver, we really do want a true global budget in the sense that we really do have that predictability. And, you know, today we still have to go through an actuarial process of setting rates. And that's not Lori's want or our want, but that's a CMS requirement, right? You still have to go through that actuarial rate setting process. So even though at the statewide level, we have to hit that 3.4% target at each CCO level, you know, we're rated each year, and our rate of growth is reviewed each year. And as I mentioned before, you know, some years we've met the global budget target and some years that we haven't. But still, as a CCO, we're trying to get everybody to work towards that same global budget target. And so I think the thing that's allowed us to get buy-in on the concept is really the approach, this crawl, walk, run type of approach to taking risk, to implementing alternate payment methodologies, and really telling providers, if it doesn't work for you, we're not going to keep doing it. We're going to stop, and we're going to change, and we're going to be your partner in doing that. And we're not just going to try and force a policy or force a payment methodology. I talked about capitation before for primary care. Well, if you're a really small clinic that has 250 attributed members, capitation is probably not going to work for you. There's too much, right? So we're not going to force that issue. And we'll work with you on meeting quality and other metrics, and we'll work with the bigger providers on those sorts of models. So I think flexibility, trust, knowing that if we do something that's not working, we're going to change it. I think those are the types of things that have gotten us buy-in.
Very helpful. Thank you, Sean.
Thank you, Sean.
Thank you,
Let's take time. Let's entertain one more question before we break, and I hope there are some of either Lori or Sean.
Patrick, this is Laurel. I saw that Sam had put a question in the chat a little earlier.
Sam, do you have something in addition to that? I thought we've answered that, but maybe not. Sam?
I believe we already answered that one.
Okay.
You did.
Yeah, that's what I thought. Okay. Is there anybody from the Washington Healthcare Authority on the line that would like to give a comment to what you just heard about our sister state to the south? I thought we were going to have some folks. I haven't checked the entire list yet, but from HCA.
I think Chase is on the line.
Yeah. Hi, can you hear me?
Yes, we can hear you.
Yeah, no, just excited to be part of the discussion, and yeah, I think we have lots to talk about, and some alignment in terms of themes around equity and social interventions for sure. I think you know, I don't know if we have time for a question. I think my question was just, you know, to hear a little bit more about the legislative side of things, but I'll defer to the Greater Columbia team on if there's time to hear from Oregon a bit on legislative involvement in your upcoming renewal work.
Why don't we quickly take that question? That probably is a Lori question, but Sean, do you want to weigh in, and then we'll take a break?
I can weigh in.
Yeah, it's a good Lori question.
There is a bill that was that pertains to CCOs, and it was developed by a couple of, at least one CCO down in the southern part of the state. But it was done in hand in hand with our regional health equity coalitions, or we call them RHECs. And it actually lays out, kind of starts to spell out this requirement that CCOs invest in community. So we're watching that. We have engaged the regional health equity coalitions in our direct work. So we're meeting with them weekly on it. And they want to have an oversight committee as well to make sure that the funding, goes out and is spent appropriately. We haven't figured out what that model will look like. It's probably going to be also some kind of shared savings in terms of, off the CCO's profit, so that there's not, but we're working out those details still. And it, so that's the bill that's happening now. Now they're going to put a definition of the global budget in there. I'm not sure, that will be in statute, but they are aware that, we have to still work that through with the federal government. So there has been a lot of legislative interest in CCOs and the CCO model. I presented to our behavioral health committee, and there were 5 or so CCOs that were asked to present as well. And so from a legislative standpoint, there's been lots of interest.
Right. Well, thank you. And I'll just want to clarify one point that both you and Sean have talked about, Lori, and that is a 3.4% cost increase every year. And the state of Oregon has been able to meet that target.
Yeah, so one of the things that happened is we met it at the statewide level. I would not say that every CCO has met it individually. And our Oregon Health Authority budget grows at a 3.4% rate of growth. So there's kind of all the money that there is.
Right.
So, and we have been able to meet that at the statewide level across time. So yes.
Great.
And yeah.
All right. Well, that's something I'm sure that the ACHs in this state will be talking about with HCA, Healthcare Authority, going forward, is that global budget and the rate of increase. So if you and Sean can stay on the line after the break, that would be wonderful. We're going to hear from one of your compatriots from, I assume it's in the Bend area, Donna Mills, the director of the Central Oregon Health Council. And then if we have any time after that, we will take questions and have more of a discussion, and perhaps have questions for you, Lori, and perhaps for you, Sean. But we typically have a break right now. We're going to extend the break. We're going to break just for 5 minutes and come back at 10:50, not 10:40. We've already passed 10:40. So stretch your legs, grab a cup of coffee, get some of that sprinkles on your face, enjoy the rain, and we'll be back in 5 minutes, more or less. Yeah, we'll be back at 10:50. Thank you so much, and we look forward to continuing this dialogue here shortly. Well, everyone, welcome back. Hope you've had an opportunity to stretch your legs. And we are now going to hear our third presenter from Oregon, Donna Mills, as you can see on the screen there, from the Central Oregon Health Council. And I'm sure I'm not alone in wondering how all this fits in together. And so I hope you will be able to touch on that, Donna. I'm sure you will. So with that, the floor is yours for the next half hour.
Great. If I could get, oh, great. So, hello, everybody. Thank you, Chair Jones, and thank you to the GCACH for asking me here today. And I'm telling you, it's a pretty tough act to follow when I have Lori Coiner and Sean Jessup in front of me. But the reality there is they have really set me up for to tell our great story. So I so appreciate my colleagues and all the work that they do as well. So next slide. My name, of course, is Donna Mills, and I have the distinct pleasure of serving as the Executive Director for the Central Oregon Health Council. And in a nutshell, what we would consider our value proposition is that we do partner with our communities, which would be Deschutes, Jefferson, Crook counties, and Northern Klamath, to guide and align vision, strategy, and activities across industries for a healthier Central Oregon. So part of what I put here on this particular slide was really to just go over a few fine points of how we fit into, but are not a part of the CCO. We are an independent autonomous 501c3, but we do have governance responsibility over our CCO, which in our region would be Pacific Source, which actually holds 4 contracts with OHA in 4 different regions. And with that, we have a joint management agreement, which I'll talk about in just a few minutes, but that enables us to be responsible for what most in the state call their CHA and CHIP, or Community Health Assessment and Community Health Improvement Plan. Ours, in fact, is referred to as a regional health assessment and a regional health improvement plan. It may not seem that important, but it became very important to Central Oregon when the CCOs were first stood up. There was already this entity within Central Oregon called the Transformation Team. And that Transformation Team held themselves responsible to the community for working over and above silos to bring a healthier care and delivery system to the people of Central Oregon. And when the CCOs came to bear, it seemed like a perfect transition to really create an entity that would be the community arm of the CCO. And although I'm probably somewhat biased, I think it really worked. So we actually have legislative authority, which requires the Central Oregon Health Council to have seated on our board, not unlike Sean's immediate board, but our governing board, those folks that actually are at risk for the Medicaid population through their contracts with the CCO. We also have representation from each of the counties from a county commissioner perspective. And then we have the not usual suspects at the table, which would be, education, long-term services and supports. But like I mentioned, we are looking always to the leadership, the people that have authority within their organizations, i.e. CEOs of the hospital, the IPA, the FQ, to make sure that they have decision authority when they come to the boardroom table working for the Health Council and can actually make decisions on behalf of their organizations, so that when we go out into the community to do this work, we know that those people with the boots on the ground actually have been given leadership authority from their leadership, as well as can work in tandem with the Health Council to bring these things to bear. So I made just a couple of lists of what we consider our health ecosystem, but it got really long, really fast. So I just put in everybody else on there as well. So next slide, please. This slide is fine, but I do want to say that Senate Bill 741 is actually what we have in legislation right now. And what that will do is that will actually repeal the sunset of the Central Oregon Health Council legislation, and we'll have it go into perpetuity, and remove some really archaic reporting requirements. And we think this is a really big deal for our region, because the region has come to trust the Health Council, sees them as a community arm, very neutral, and really taking care of the entire community without having to, how do I want to say that? We only have one constituency, and that's our community, if you will. So next slide, please. And just so, because I didn't want Sean to have the whole half of the state that he actually represents, I did want us to get called out there right in the middle. What's interesting is that the Medicaid enrollment is just about the same as it is for Sean, but in a much more smaller footprint, if you will. And I do think that that's important, because I do think that that makes a lot of difference. And as you can well imagine, we do have rural areas in our catchment, but certainly nothing to the degree that Sean has. So next slide, please. Okay, so I wanted to depict a little bit, most people get really interested really fast around what the business model looks like between the Health Council and the CCO. So this is our joint management agreement. It has changed and been edited a couple of times over the years, but this is where it is currently, and this is what I want to address today. So how does the Health Council survive? What's our revenue stream? So the Health Council receives 0.325% of every Medicaid dollar to run our operating budget. That has been a flat amount for the last 6 years. And that's what pays our staff. We have 6 staff members. We have 3 project managers and a grants and metrics manager and 1 admin staff. And then myself, of course. We run a very lean ship, as you can well imagine. So for Pacific Source, you can see from Oregon Health Authority, has the contract with the CCO. The CCO has requirements that they have to take care of in their expenses, as well as all of the provider contracts. The Health Council does not participate in negotiating those contracts, and frankly, keeps a really thick, dark line between the contracts and the Health Council. And then in addition to that, what we're getting paid to do, if you will, is to have and Sean referred to it, the Community Advisory Council, any finance committee, we call our clinical advisory panel a PEP, a provider engagement panel. And we also hold all of the committees and the councils that are required within the CCO 2.0 contract that touch the community. And then, of course, we are responsible for creating, or should I say, gathering the information for the regional health assessment, and then turning that into the regional health improvement plan, which in fact turns into 6 individual work groups, which we'll see in just a second. And then the community having the metrics of which they need to make decisions of where they invest into the community. So that 1% that you see under the 0.325, that is specific to the regional health improvement plan. And that funding is the 1% of what comes into the CCO that is not, there's a little bit of calculation that comes into that, but it ends up being about $2.5 million on an annual basis. And that funding is specifically restricted to moving the metrics within the regional health improvement plan. Next slide. So I wanted to depict a little bit of the rigor that goes into creating and bringing together the regional health assessment and the regional health improvement plan, and what the Health Council has done to really go through. We've gone through, this is our 3rd iteration of the RAW and the RIP, and we actually gather folks from the community to come together to be at a steering committee to pull together those assessments. That health assessment takes about 2 years to complete before we can have it ready to go to our board. And our board, in conjunction with our clinical advisory council, come together for a day, and they determine from that health assessment what really has bubbled to the top and what metrics that the Regional Health Improvement Plan will include for the next, and we've just changed to a 5-year cadence, but for the next 5 years. And I'm going to reach back here. And I don't know, here it is, because I want to show it to you because it's so beautiful. Let me see. There we go. We've printed a lot of these before COVID, and then clearly have used the electronic copy a lot this year. But we in this process this year, we had decided that this paper process of doing the qualitative and quantitative investigations around the health assessment, we might be better served to make that something that looked a little bit more digital. So the Health Council actually invested in a platform last year called our Community Data Dashboard, which is available to anyone and everyone, even for people from other states, to take a look at. And it tracks a little north of 300 data points in our region, comparing us to other counties, to other states, across the nation. And we just feel that that's going to be a great tool for the community to use going forward when we need to do the next regional health assessment and regional health improvement plan. Next slide, please. So the RIP priorities for 2020 to 2024 were a little different than our previous two regional. You can go ahead to the next slide. That would be fine. So I didn't get here until after the first regional health improvement plan had been created, and it was clearly because folks were trying to boil the ocean, and that typically happens. So when I got here and we were ready to launch our next one, we actually were pretty focused on disease states. So our priorities were really focused around specifically oral health, hypertension, behavioral health stuck, and then a couple of social determinants of health, kindergarten readiness, and then housing. So when we came in to do this particular regional health improvement plan, we really kind of took a zoom out approach, if you will, and said, you know what, why don't we talk about the maladies that are creating these disease states? And then you can drive a truck through the regional health improvement plan. There's all these metrics that are actually in it. But since we know there is so much social determinants of health that feed into these disease states, that we think it partnered really well. So I certainly don't need to read them to you as much as wanted you to be able to take a look at them. And I'm sure these slides are available post presentation. So next slide. So what's important to us and what's important to our communities is who participates in these work groups. So the Health Council facilitates these work groups. And we have the normal folks that you would think would be there, i.e. health clinics and hospitals. But public health, we work hand in hand with public health as well as behavioral health and housing and education. This particular RIP, we actually have about 5 retired community members, which we're super excited about. And of course, we do have Medicaid beneficiaries. And something I failed to say earlier was, although we're funded with Medicaid dollars, our population is population health. We are about everybody in the region. So it's not, these investments don't just go for Medicaid recipients, they're for all recipients, because we recognize that population health is regional health. So we just really, I wanted to emphasize that. So currently we're at about 160 unique volunteers. There are folks that actually participate in more than one work group on a regular basis. Next slide, please. So how are the projects funded? So like I had mentioned, the work groups come together to decide how the metrics can be addressed and what they want to do. And at the end of my presentation, I'm just going to give you a couple of examples of things that have been funded. But they really are looking for super innovative projects. And the Health Council has always been one to say, we love to seed pilot projects and innovative projects. And if they work, that's great. Let's hand them off to somebody who can keep it sustainable. And if they don't work, you know what? No harm, no foul. We actually tried it, and we hope to remember we tried it and don't try it again, unless we make some tweaks to it. We do a number of different processes for inviting the region to submit. It can be a letter of interest. It can be a request for proposals. As long as it aligns with the metrics that are in the Regional Health Improvement Plan, the work groups will look at it. And then the work groups go through a pretty rigorous review and scoring process. I also wanted to mention, Sean also had mentioned the Community Benefit Initiative funds and the share funds. Those funds are also managed through the Community Advisory Council, of whom we have taught and trained to go through these review and scorings so that they can be very proficient at looking at grants and what to look for. So next slide, please. So I actually, this is going to be the fun part. So there's a couple of projects, and actually I'm going to speak to 3, but I only have slides for 2. But this project called Culture of Care came to the Health Council a couple of years ago, and it actually came out of the High Desert ESD, which is the learning district here for Central Oregon. And we have a couple of them, but they were in partnership. But what I wanted to point out about this is that this was about resilience and attending school regularly, and how that led to increased graduation rates, and how it actually created some trauma-informed professional development for folks that saw students. And what was important with this particular investment was that there was no healthcare stethoscope and thermometer involved in this grant at all. This was all about the schools coming together with the folks that they would typically work with and for, and recognizing the causes of trauma and how that affects our health and well-being. I think that it's been spoken to quite a bit today. There's also this, the equity and diversity arm, and making sure that we are not continuing to perpetuate systems that have continually exaggerated and oppressed the lack of care and services that we provide for certain members of our communities. So this is one that we have found has been amazing. And then what is another part of it that's amazing, and I like to say never waste a good pandemic, is that they were able to pivot and step into this care for our community, these trainers, and step into our community and help those that were in need when the schools closed. And we're able to push some of those dollars in another area. Of course, they asked for permission, but in other areas that brought value to our community and really started to galvanize how our school districts were working with not likely partners like public health, and working with not likely partners that we would not normally see them in our commerce and in our business sector. So that to me is really an indication of how the community kind of came together and used something that was already in place, and that the Health Council was there to be able to shepherd and convene those parties together so that that could actually be achieved. Next slide, please. And then this one is near and dear to my heart, the perinatal care continuum. So this is one of the first projects that was funded through the Health Council when I got here. And it was amazing to me to see how many young women, maybe they're not all young, how many women were not seeking care in their first trimester of pregnancy. We recognize that some women don't even know that they're pregnant in the first 3 months. However, that wasn't really the most of the driver of this. It was everything else in their lives was more important. And we all know the importance of early, first of all, pregnancy detection and how you can take care of yourself. But this program actually was a partnership, or is a partnership with public health. So public health has their prenatal care continuum nursing staff. And those folks actually go into the OBGYN and identify high-risk women, and then they quote unquote attach themselves to that woman, and they do not leave that woman until after that baby is born. There is lots and lots and lots of evidence about the value of reducing low birth weight babies. We know one NICU baby is clearly over $1 million these days, but really bringing some success to these gals and their families. And then these people become friends with them within the community. It's been extremely successful. You can see those are just the percentages over this last couple of years. And we're actually going to do a formal evaluation of this program. One of the really cool parts about it is that there is an aspect of this that is now a covered benefit from OHA. So at the end of the day, when the Health Council is funding innovative studies or anything that's new, the fact that it would become a covered benefit to us is a win-win. Of course, if it was up to us, everything would be covered in prevention, but we know that that isn't necessarily always the case. So you can go to my closing slide, but I just have one other one that I wanted to just bring to your attention, and really because I heard you all talking about it and I heard Sean mention it. So in Central Oregon, the Central Oregon Health Council holds the contract currently for the Unite Us platform contract. And Unite Us is the community information exchange. And we are, we launched in September. And so we are about to transition our contract to Pacific Source. So this is a perfect example of where the community came together. They wanted to do something around a closed loop referral bi-directional platform for social services. They picked Unite Us. The Health Council funded it. We're also working with the state on those efforts. And we are so excited that it's working so incredibly well that hopefully I'm going to tie the bow on it pretty soon and hand it off to Pacific Source. So, recognizing that, and again, really want to thank Lori and Sean for setting me up for success here today, because this is the boots on the ground, getting to do the community work. And I just really appreciate the opportunity to share with you today. I'm always available for more comments. Please go out to our website. There's so much more information. There's about $22 million have been put into our community since 2015. So thank you so much, and certainly available for questions.
All right, Donna, thank you. That was definitely enlightening and illuminating. And I hope we have a couple of questions for you. You can see here, you can raise your hand, or perhaps you're more comfortable just using the chat box. While we're waiting for these to come in, Donna, let me just ask the question, is there an equivalent of your organization in the other CCO geographies of the state, or are you unique?
We are unique. Both the Central Oregon and the Columbia Gorge were, when the CCO stood up for Pacific Source, those two were the maiden voyages, if you will, of the health councils. And then when Pacific Source submitted their proposal for CCO 2.0 and those two additional regions, they actually submitted with an arm for a health council. So now we have a health council in Marion Polk and actually in Lane County as well. Those are my sister CCO, our sister health councils. They call me their big sister. So.
All right, so it's not universal, but it's growing, the use of health councils.
Yes, sir.
Okay, here's a question from Laurel, and the question is, who participates in the convening and decides on the community information exchange content?
Thank you for that question. So the convening was the community. So if you can imagine one of the regional health improvement plan work groups, they were actually working on nutrition was what started that conversation. And it was the folks from the health system and the FQ specifically that came together and said, we are having so much trouble with getting our diabetic folks good nutrition when they discharge from the hospital. We don't know how to connect them. We don't know what to do there. And so that created a larger conversation within the group. And they said, hey, what we don't have is we don't have a referral platform, closed loop referral platform to know once we send Mary to go get food, whether she gets it and any way to find out if she got it. And so that when we're trying to have this did my diabetic patient go get what they needed? Were their needs satisfied? If there was a way for us to know that, we could be much better at helping them manage that. And so then we vetted, I believe, and they did all this work. So it was Aunt Bertha, Care Everywhere, and Unite Us was actually one of the vendors that came forward, and Unite Us by far outshone the rest of them.
All right. Okay. Does that answer your question, Laurel? Well, while she's responding, any more questions of Donna and the Central Oregon Health Council experience?
This is Laurel, and sorry for the delay. I was just wondering, so you mentioned the community were the participants in the convening. So did you have representation from the primary care providers in that convening?
Yes. So we, short of maybe some of our really small providers that just actually don't have an opportunity to send someone to a work group meeting, we do have representation from primary care. We also have a Central Oregon IPA here, and so they have representation in their practice management staff that come on behalf of our smaller, more rural clinics.
Yeah, I'm just thinking, you know, that most important part that I'm hearing you speak of is that buy-in, that initial buy-in when the decision is made, that everyone has a voice. So I really admire that you are able to have that going in to decide on your CIE.
Thank you.
All right. Any other questions of Donna?
Donna, this is Carol.
Hello, Carol.
Thanks again for presenting this morning. Could you talk a little bit more about that dashboard? I know that Patrick's shop does dashboards for communities with lots of measures that are available to the community at large. Could you talk more about this dashboard that everybody can access?
I'd be absolutely happy to. And if you'll beg my indulgence, I might even get the link in the chat, but no promises. I might have to send it later. But and again, we at the Health Council actually went searching for just the right platform for that. And we actually settled on Conduent. And the reason we settled on them is that they were able to, for the most part, meet most of the data points that we wanted to add and had the most flexibility. So we were able to, it took us about a year to set it up. But we were actually able to take the metrics from our regional health improvement plan, load them in, see if there were other institutions, you know, albeit educational, other health departments, whoever it was, that was gathering this data on a regular basis. So we would be able to refresh our data. And working very closely with the public health departments. They were our partners in this, and their epidemiologists, and saying what they really felt would be important for us to have. But now we have both the quantitative and qualitative data in there. And I think that that's what really makes it fun. There is like all kinds of prevention information. There's all kinds of any of the grants that we have distributed that have actually moved the metrics are included in the dashboard. So if somebody doesn't have to recreate the wheel, they can say, oh, look what Central Oregon did. Maybe we should try that. So I will now attempt to put the link in the chat.
All right. Thank you. Thank you. We appreciate seeing that. Why don't we just throw it open in the remaining minutes we have here? If Sean's still on the line, or if Lori's still on the line, which she may not be, to see if there's any questions about. Thank you, Don. That came through well. If there are any questions of the Oregon experience writ large that you have and indirectly might inform our work. Okay, Sean just saying he's available, so that's great. And Lori's there as well. Thank you so much for staying online. I'll just speak for myself and saying, as I mentioned at the start of the program, that this is something I've been advocating for at least a couple of years, because we think you are probably a couple of laps ahead of us. After all, you're going for your third waiver, and we're still working through waiver number 1. And so there's undoubtedly things that we can learn from you, and appreciate that. So any questions of Donna, Lori, or Sean from their different perspectives? Thank you, Donna. Yeah. Okay.
This is Chase, with nobody else chiming in with the Healthcare Authority with a question here. Was there any, was there agreement, I should say, between the CCO and the Health Council, the concept of the Health Council? Was there anything to work through there initially?
Well, I wasn't here, but what I can tell you is that the governor's office had actually come to talk to that transformation team that I was talking about and said, what do you think? Does this seem like a good idea? Could you try it? Maybe. And my understanding is that Pacific Source was very open to it. And again, I would love to have been a fly on the wall as they were hashing out the joint management agreement. But I think that it's really incredibly notable and admirable how, as a community, they came together. And yes, and I can tell you, we have a wonderful relationship, and we're actually often mistaken for being the CCO. I think that kind of speaks to how closely together we work. Thank you for the question.
Okay. Does that answer your question, Chase?
Yeah, thanks so much.
Okay.
There's
Penny,
a question in the chat. Yeah.
Yeah, here's a question in the chat box. And I don't know whether this refers, so I thought I heard that behavioral health was not a part of the waiver request being made in December. Can one of you speak to that as to why? So I assume this is, Penny, you're talking about Oregon, not Washington, right?
This is Lori. I can speak to that. I have a couple of answers to that. And I will say that the focus of the waiver is not behavioral health. It's really on equity, but we do have pieces that will affect behavioral health. And so, like I was describing, we're focusing on transitions of care. So some states have focused, for example, on certain complex conditions. So it might be having a physical and behavioral health condition, and those patients or those members get access to housing supports and services, for example. We've decided that I think that rather than looking at diagnoses, really focusing on those members that are undergoing that kind of transition, for example, from criminal justice to community, does affect a lot of folks who have behavioral health needs. And but the waiver isn't specifically focused on behavioral health. And part of the reason is we have lots going on in the legislature right now around behavioral health, and CCO 2.0 is focusing on behavioral health, and our overall, and a lot of those changes, frankly, just don't require waiver authority. So when you have a waiver, you're really asking the federal government to waive managed care rule. And we don't believe that we need to waive rules. We need to put some money in the system and think about how we operate differently. And so that doesn't require waiver authority. So hopefully that's helpful.
Thank you, Lori. That helped, I think. Okay, just to wrap up with a final question or two. We have all three speakers still with us, and I'm sure there's more that we can learn. So let's take advantage of just this waning period of our session to learn even more. Okay, I'll use the prerogative of the chair here at the meeting and just say to all three of you, would you have any recommendations for your state to the north, for Washington? if you're familiar with our Accountable Community of Health organization, would you, maybe you're not, and so that's something you can't comment on, but how can we learn from you?
This is Donna, and I would just say, this is the beginning, hopefully, of a growing relationship. I think that as states, and especially so close in geography, we can learn so much from each other. I actually know the Unitas footprint, actually what we're calling Connect Oregon in Southwest Washington, actually has some footprint there, and maybe there's some synergies that we could leverage. Especially some learnings. I can surely share with you some opportunities you should be looking for, so you don't have to stub your toe on those. But I'm always interested in hearing how other folks are doing it. I mean, I know that you do have a responsibility for also investing dollars into the community, and I think that we can learn a great deal from one another, from grant platforms to application process. And so I would love to have further conversation. And I actually plan on calling Carol. So there you go.
All right. Thank you, Donna. Lori or Sean, did you have any quick comments to that perhaps provocative question, or perhaps too open-ended question?
I don't fully understand, admittedly, the model that you're working under, but I would just say, engage the providers, engage public health, and engage your community, because you need everyone rowing in the same direction, regardless of which direction you want to go. You need all of them. You need everyone to be rowing in the same direction with you. So that would be my advice. And we didn't have a lot of that when we started, and we had to develop a lot of that, but that's allowed us to be successful.
Great. Thank you. Thank you, Sean.
This is Lori. I think doing what you're doing now and talking to others about what's worked and hasn't is a really great way to go. I also am glad to hear that the healthcare authority's on the line, because I think you really need partnership with your healthcare authority and then also with the managed care plans in order to make it all work. And hopefully there's appetite to have some funding skin in the game, so that communities have access to dollars that they can invest in ways that meet that particular community. And I think that's been a real success with Donna's organization, for example, that Pacific Source is committed to that partnership. So
thank you.
Thank you. This is Sean. Lori made me think of one other thing to add, sure, maybe for the healthcare authority, and I mentioned this in my talk, but have some extra dollars out there as a carrot. Oregon did such a good job of putting quality dollars out there as a bonus if we all achieve metrics, and that really helped with conversations. It helped with buy-in. It gave us something to work towards rather than the penalty for not meeting, but have a carrot for meeting something above and beyond. I would recommend that.
Good idea about plan design there. Thank you, Sean. Well, can we give a round of applause to our three speakers, and thank you so much. That was superb. I think we'll be, at least I will be, and I hope many of you will be chewing over this for a few days to come, if not longer. Just a reminder, please fill out the quick little survey on SurveyMonkey before you log off. And Carol, do you have any final comments?
This has been a long time in planning and coming. Lori, again, apologize for some miscommunication this morning, but thank you for joining us to the end. Thank you, Sean and Donna. It's been great. I love the state of Oregon. I'm glad that we are partners and that we will be reaching out and learning more from you guys about how we can be more sustainable in the years to come.
Great. Thanks for having me.
All right. Thank you, Lori. Thank you, Sean. Thank you, Donna. Thank you, everyone, for coming. There will be a June meeting, and stay tuned for that. As always, it'll be the third Thursday of June. So with this, we are adjourned. Have a great day.
Thank you.
Thank you. Thank you, everyone.